Thank you very much. It is as usual always hilarious, and of course this is the first day, Saturday morning, where our 80% physicians are in their consulting room. So this is there are very few who are so clinically inclined and they are here. So my lecture today is on Inclisiran, and let me be very frank with all of you. This is the new molecule which I have never used. So our specialty is interventions. To talk about something which I have never used is something new. But I thought that this is a challenging because there are a lot of new advances taking place in cardiology and in lipidology. So I thought we should at least talk on some topics which we are not used to at the moment. This is a disclaimer. Now all of you know that atherosclerotic cardiovascular disease, which also includes cerebral vascular disease, is very high mortality. It is so high that by the time Chaitanya Bhuj gave the introduction, 30 people must have died because of this disease. And by the time my lecture is over, it would be 300 to 500, and by the time our conference, 7,000 to 8,000 people. So you can imagine the impact of the coronary artery disease and how many people can die because of coronary artery disease. So once patient has coronary disease, you are too late. So we have to try to do something to prevent this disease, and we are having a lot of medicines and other things to do that. And those who already get one heart attack, as for example acute coronary event, the chances that they get second event in next few years is as much as 6 times compared to normal populations. For stroke, it is even worse. It is 9 times more. So that is quite high and dangerous. And there are many risk factors, but today what I am going to concentrate is on LDL cholesterol, which is one of the very powerful risk factor for coronary artery disease. And we have a lot of technology to control the LDL cholesterol, right from diet style to lifestyle to statins, which is one of the cornerstone of the treatment. Like smokers, you say what is smoking years, means number of cigarettes per multiple years. Similarly, they call what is known LDL years. So more the LDL level, more longer time it remains higher, and for so many years it can cause a plaque. All of you know that probably coronary artery plaque starts developing as early as 7 or 8 years of age. So we have to act quite fast, quite aggressively if you want to reduce the coronary disease mortality. If you cannot achieve that LDL target, you know the mortality rate is extremely high. Unfortunately, in spite of doing our best, a lot of people they remain who are not to the target of LDL control, especially those who are very high risk patients, and that is what causes all the problems. So we know that statins are commonly used for reducing cholesterol levels for primary as well as even secondary prevention, but more effectively for secondary preventions. But in spite of very effectiveness of statin, only half of the people can achieve target levels, and in rest of the it is myopathy, fatigue, and many of the side effects of statin which patient cannot tolerate. And unlike Americans, Europeans, probably even Indians, they have more incidence of myopathy. I have seen many people just with even 10 milligram of atorvastatin or 5 milligram rosustatin, they get complaint myopathy. The moment you stop them, that symptom disappears. And they are more worried about acute day-to-day symptoms than dying of coronary artery disease in future. So they are the one who we have to stop these medicines. And in spite of that, when there is a residual event, at the end of first year, 10%, second year 16%, 3 year 20%, they develop coronary artery problems. It's either because they are not effective, or there is poor adherence, or there is side effect, you have to stop them. These are the problems that is. So what is the recent breakthrough that Chaitanya Bhuj very rightly said is discovery of PCSK9 inhibitors. Of course, it was discovered 20 years ago, but with more and more molecules and options available, now we have realized that it is probably going to be used in our life. At the moment, because of cost and because it's not available in oral form, the use is not as much. But we have already evolocumab, erokumab, and lastly Inclisiran. These are the 3 which are PCSK9 inhibitors, which are not available in oral form. They are given in subcutaneous form. But those who are either statin intolerant or those in whom statin is given in maximum doses, still we have not desired effect, it can be added, and that is what I am going to discuss today in short. This is definitely a new molecule. It's a small interfering RNA therapy. It's analog to the naturally occurring RNA, and it is 2 strands. One is passenger strand, second is guide strand. So with the help of passenger strand, this particular molecule gets attached to predominantly hepatic cell. Means 90% goes into the liver cell, and because of its so-called guide strand, it mimics the messenger RNA or natural RNA and does the job that it should do, that is reducing PCSK9 protein, which is responsible for inhibiting the LDL receptors or liver cells. So if it is a very complex slide, but just to make it simple, you can say there the blue color, they are the LDL receptors. Their job is to take away LDL from the circulation. So if the LDL receptors are more LDL can be taken up and LDL level goes down. The purpose of PCSK9, which is naturally occurring protein, it interferes with LDL receptors, and more the PCSK9, lesser is the lipid absorption and more is the lipid in the blood. So by any means, if you can reduce PCSK, you can increase the LDL receptors available to take care of LDL in the circulation. And on this side, you can say this is Inclisiran. It joins to special ligand which is known as ASGP receptors, and then it goes into the circulation. It acts with the risk. I have written it. Inclisiran reduces risk by combining with the risk. Risk is a RNA molecule which in that turn destroys or destructs the PCSK9 messenger RNA, and lesser the level of PCSK9 messenger RNA, more the LDL receptors available to take care of LDL from the circulation. So it's very complex, but the thing is, this is for the first time different mode of action, and so it can act as synergy with the other available molecules that we have. Usually all the medicine we use are given orally, and oral is not a problem, as very previously slide shows that patient prefer oral tablet better. But if you take daily oral tablets, some people prefer once or twice in a year injection far better than the oral tablets. And we have seen many people with insulin, they are ready and happily taking 2 or 3 doses of insulin each day. But if you say that we can give you insulin once or twice in a year, I am sure that will be extremely happy. I don't know whether this type of insulins are available or not, but if that is the case, patient always like it. So what would be the advantages? See, it's a definitely new molecule acting in very different fashions, and once it's given like subcutaneous, within 48 hours is no more seen in the circulation. 90% of that goes into the liver where it has to act. And the biggest advantage, it is subcutaneous, given only twice a year. Of course, first injection is on day 1, then after 3 months, and thereafter twice in a year for the rest of the life. The only downside probably at the moment is extraordinarily high cost. So if you compare with statin, it is to be taken each and every day. If you compare to PCSK9 inhibitor that is available, monoclonal antibodies, they are taken 15 days, once in a 15 days, that is almost 26 times in a year. While Inclisiran, the new molecule, it is given subcutaneous only twice in a year. So that is probably one of the biggest point that patient would like. And not only that, the reduction in LDL is much more compared to existing lipid lowering therapies put together. So this may be one of the biggest advantages. We have to still yet to see what would be the clinical benefit and how much would be the reduction in coronary artery disease. But all the trials of statins have shown lower the lipid levels, more is the effect and control on the statins. That is what you've seen. And there are almost 12 trials. I don't know, the ORIER is not acronym, but these are the 12 trials depending upon which phase of clinical investigation was used. And the final summary I will show you a little later. It shows almost 50 to 60% reduction in LDL levels, and it was seen in more than 50 to 70% people. Compared to statin or other therapy, the achievement in LDL threshold, we consider very stringent target of 70, because initially we were happy if it is 160, then it became 130, then we realized lower the better it is. So those who are already proved coronary artery disease or very high risk for coronary artery disease, 70 is the target. Even lesser than 70 may be better, like 50 is. So we don't know what is the lowest possible target available, but lower it is, better it is. That is what is seen. So if you compare it with the placebo, obviously effect is phenomenal. Here you can see total cholesterol, non-HDL cholesterol, where LDL is obviously biggest part, and bad cholesterol, that is ApoB, all are reduced in the tune of 30 to 40% compared to placebo. That is the biggest advantage. If you say side effects, there were a very minimal side effect related to injections, and they were almost equivalent to any subcutaneous injection. So side effects were almost similar to placebo. No major side effects like myopathy or other liver problems were seen with Inclisiran at initial. Of course, many of the side effects you can see after molecule is used into circulation and in real life. You often don't see side effects during trials. Like we had a Johnson & Johnson stent, and it was 0% risk cirrhosis. We were all greatly happy. But when we started using it, we realized no, it is 10 to 15% still. So in real life, scenario may be very different. But this is what we have seen in different trials, that almost 70 to 80% reduction in target that we want to achieve. I will not go into detail about it. So basically, phase 2 and 3 trials have been done, and fortunately there is a single dose. It's a 300 milligram sub-Q day 190 and then 180 days each time or twice in a year. At the moment, safety profile is as much as any placebo, and more than 3,500 people are already on this for more than 1 year plus. These are the guidelines how to use it. It's predominantly used at the moment for secondary prevention in those who cannot achieve target of LDL in spite of optimum or maximum tolerated dose of statin, plus minus ezetimibe, plus minus other lifestyle changes. So the advantage is, as I previously mentioned, twice a day, twice in a year, very much effective, very minimal side effect, very well tolerated. So this is just summary of hyperlipidemia, lifestyle modification. You should not consider that is off. It's almost always there. Then statin, that is one of the most important. They decreases cholesterol biosynthesis. Now we have bempedoic acid also, which can be added to statin. If this fails, you add ezetimibe. Fibrate is obviously another add, and saroglitazide, our Indian molecule, also known as lipaglyn. When all this fails, obviously PCSK9, any of the three can be used, but inclisiran is probably one of the winner, except cost. The ease of administration is one of the biggest advantage. And remember that 10 to 20%, even more number of people are statin intolerant. They have huge amount of statin induced side effects, which all are nullified or not seen when used inclisiran, which is the biggest advantage of inclisiran. And this is how we can use it. We can see inclisiran is used in cases with limited statin efficacies. In real life, it's a new player, and I think that is what we have to use. So I think I will end it here, because new molecule, I'll not go to detail, but if there is any question or any suggestion,